Imagine you have to patch a leak in a pipe.
Right.
Seems easy enough, right? I mean, you get a wrench, a clamp, maybe some sealant, and you just tighten it all down.
Standard plumbing.
Exactly. But now, imagine that pipe is, well, it's soft and it's constantly moving.
Oh, and it's pitched in total darkness.
Yes, total darkness, and surrounded by incredibly sensitive vital wiring.
Yeah.
Oh, and you have to fix it from like 10 feet away using only a fishing line and a microscopic bear trap.
Which is, I mean, that is precisely the high-stakes reality of modern gastrointestinal medicine.
It's wild.
You aren't just fixing a pipe. You're navigating a living, breathing, incredibly delicate labyrinth.
Which brings us to the focus of today's deep dive. We are exploring the fascinating and honestly somewhat terrifying mechanics of over-the-scope clips, or OTSCs.
Right.
And to do this, we were pulling directly from a highly detailed tutorial video. It's titled HCC 1975 28B OTSC Clips, uploaded by Gatamukala S. Raju.
An incredible resource.
It really is. So the mission for us today, and for you listening, is to completely demystify how medical professionals perform this microscopic, life-saving plumbing inside the human body.
Because it's a massive leap forward in emergency medicine.
Oh, absolutely.
Like, before these specialized mechanical clamps existed, if a patient had a severe internal bleed or a large perforation.
Like an actual hole in their digestive tract.
Exactly. It often meant immediate, highly invasive open surgery.
Yeah.
You had to physically cut the patient open to get to the problem.
Right.
But now, doctors are essentially doing these deep-sea repairs using a flexible tube and these incredibly powerful tiny clips.
I love that visual, by the way, deep sea repairs. But before we get into how they actually deploy these things in the dark, we really need to understand the anatomy of the tool itself.
The hardware.
Yeah, the hardware. So an OTSC comes mounted on this transparent cylindrical cap.
Right.
And that cap gets loaded right onto the very tip of the endoscope, you know, the long, flexible camera tube they use to look inside the stomach or intestines.
Yeah, but the clips themselves, they aren't all the same.
Right. I was surprised by that.
The engineering here is heavily specialized. Like, Raju's tutorial highlights 3 distinct types of teeth on these clips.
Because you need completely different physics depending on the tissue crisis you're facing.
Exactly. So first you have the type A clip. This one features blunt, randed teeth, and its primary function is hemostasis.
Stopping a severe bleed.
Right.
Okay, wait, hold on. If I'm trying to clamp down on something slippery and wet that is actively bleeding, why would I want blunt, rounded teeth?
It sounds weird, right?
Yeah. Wouldn't
Right.
I want sharp spikes to really, like, grab onto it?
It seems counterintuitive until you look at the mechanics of a blood vessel.
Okay.
If you have a ruptured, bleeding vessel, the tissue is already compromised. It's weak.
Right.
If you bite down on that with sharp spikes, you are going to puncture the surrounding healthy tissue.
Oh, wow.
Yeah, potentially creating a brand new leak.
So you're making it worse.
Exactly. Blunt teeth work on the physics of compression. They just crush the vessel flat without piercing it,
Ah, okay.
which physically blocks the blood flow and, allows the body's natural clotting process to take over.
That makes perfect sense. It's like stepping on a garden hose with a flat shoe rather than a golf cleat.
That's a great way to put it.
Okay, so what about the other 2 types?
Well, then you have the type T clip, which features short, sharp spikes.
Okay, so spikes this time.
Yes, because this one is specifically designed for closing perforations.
The holes.
Right. When you have an actual hole in the stomach or intestinal wall, you aren't just trying to compress a vessel. You need to physically drag the 2 torn edges of the hole together.
Like pulling fabric together.
Exactly. And anchor them securely. So the spikes penetrate the mucosal layer to ensure the tissue cannot slip out of the clip's grip.
Got it.
And finally, there is the GC clip, which utilizes much longer spikes. This is preferentially used in the stomach for something called PEG site wound closure.
Okay, let's define that really quickly for the listener. A PEG site, percutaneous endoscopic gastrostomy.
Nice pronunciation.
Thank you, I practiced. It's basically the surgical hole created when a patient needs a feeding tube passed directly through their abdomen into their stomach.
Right.
And when they don't need the tube anymore, you are left with a fairly substantial, thick-walled hole that needs to be permanently closed.
Hence the longer spikes.
To grab that thicker stomach muscle.
Exactly. You need deeper penetration to pull the entirety of that thick muscular wall together.
Okay, so we have blunt force for bleeding, short spikes for tears, and long spikes for thick stomach holes.
You've got it.
But here is where the medical terminology completely threw me. The tutorial goes into the labeling system on the packaging.
Oh, yeah. The numbers.
Right. So a doctor looks at a box and sees a code like 11 by 3T.
Yes.
Let me just write this down. The 11 is what exactly?
So the 11 refers to the cap size, 11 millimeters.
Yeah.
This tells the doctor the inner diameter.
Inner diameter. Okay.
Right. Which dictates which specific endoscope the cap will actually fit onto.
Make sure the pieces fit.
Exactly. The second number, the 3, is the depth of the cap in millimeters.
Okay.
They generally come in 3 millimeter or 6 millimeter depths. And a deeper cap just allows you to pull more tissue inside before firing the clip.
Makes sense. And the letter T.
That simply dictates the short spike teeth we just discussed.
Okay, so 11 millimeter cap, 3 millimeter depth, short spikes.
Right.
It seems like a perfectly logical system, except
It isn't.
it totally isn't. The 11 millimeters only refers to the inside of the cap.
Yeah, that's the catch.
The tutorial explicitly warns that the doctor has to, mentally calculate the actual size of the device going into the patient's throat by adding 5 to 6 millimeters to that number.
It's a huge difference.
Yeah, so an 11 millimeter cap is actually 16.5 millimeters wide, and a 14 millimeter cap is a massive 21 millimeters wide.
I know.
Why wouldn't they just put 21 on the box?
I mean, it is a notorious quirk in medical device manufacturing. They categorize the tool by the equipment it pairs with a scope rather than its absolute footprint in the human body.
That seems so backwards.
But you are absolutely right to call out the danger there,
Yeah.
because that missing spatial awareness can be catastrophic.
Right, because you're taking this rigid plastic cylinder with a metal bear trap on it and forcing it down a delicate human esophagus.
Yeah.
And the tutorial specifically warns about patients with a condition called cervical spondylosis.
Right. Cervical spondylosis is essentially osteoarthritis of the spinal discs in the neck.
Okay.
Over time, those discs wear down, bone spurs can form, and the actual anatomical tunnel of the throat and neck becomes incredibly rigid and restricted.
Ah, so if a doctor's moving too fast, sees 14 millimeters on the box and thinks, oh, 14 millimeters, that's small enough.
They might try to force what is actually a 21 millimeter rigid object down a hardened, restricted airway.
And that is how you cause an entirely new, potentially fatal tear in the patient's esophagus before you even reach the stomach.
Exactly. It requires the doctor to possess a flawless mental map of both their tools and the specific patient's degenerative anatomy.
Wow. Okay, so if navigating a bulky, rigid cap down a fragile throat is that dangerous, how do they actually control the trap once it's completely submerged inside the digestive tract?
Good question.
Because they obviously can't reach their hands in. And the actual physical rigging of this device, it blew my mind.
It is an absolute exercise in microscopic mechanical engineering.
It really is.
The deployment system relies on 3 main components.
Yeah.
You have the transparent cap itself, which is preloaded with the metal clip sitting on its outer rim, kind of like a stretched rubber band.
Right.
Attached to that clip is a specialized, incredibly strong thread. Then you have a separate thread retriever tool, and finally a hand wheel that stays on the outside with the doctor.
The routing process is fascinating. So the biopsy channel of an endoscope is basically a hollow tube running through the center of the camera snake. They attach the hand wheel to the outside port. Then they take the thread retriever, which is like a miniature plumbing snake.
That's exactly what it looks like.
And they push it all the way down the hollow tube until it pops out at the camera end. Then they hook the thread attached to the clip and pull that thread all the way back up through the length of the scope.
And once that thread emerges on the outside, they wrap it tightly around the hand wheel, securing the entire system.
It's a literal pulley system routed through the human body.
It really is.
I mean, the tutorial notes that the setup is virtually identical to a band ligator. Is this just repurposing old technology for a new tool?
Mechanically speaking, yes. And that is a brilliant piece of design.
Really?
Yeah. Endoscopists have spent decades using hand wheel and thread systems to deploy tiny rubber bands to tie off bleeding veins. It's pure muscle memory at this point.
Oh, so they don't have to learn a whole new movement.
Exactly. By utilizing that exact same mechanical action, the engineers bypassed a massive learning curve.
That's smart.
When the doctor encounters a crisis, they don't have to think about how to fire the tool. They just turn the wheel. The wheel pulls the thread pulls the clip off the edge of the cap, and the clip violently snaps shut.
But there is one tiny physical detail in the setup that is make or break.
Yes.
Before they insert the scope, the doctor has to manually rotate the transparent cap on the tip to ensure the thread lines up perfectly with the biopsy channel.
Right, the alignment.
Because if they just slap it on casually, that thread will cross directly over the camera lens. You'd basically be trying to perform microscopic surgery while staring at a thick rope blocking your vision.
And visibility is the single most critical element of this entire procedure.
Can you imagine?
Because once that device is fully rigged and navigating the dark, wet, constantly moving environment of the digestive tract,
Yeah.
the doctor has to physically capture the damaged tissue inside the cap before turning that wheel.
Which brings us to the actual deployment.
Huh?
How do you grab a piece of bleeding tissue without making it worse? Raju outlines two foundational techniques for this: suction and traction. Let's start with suction.
Okay, so suction relies entirely on negative pressure and the natural pliability of the stomach or intestinal wall.
Okay.
The doctor navigates the endoscope right up to the bleeding vessel. Once they are flush against the tissue, they activate a powerful vacuum through the scope.
And the negative pressure physically sucks the soft bleeding tissue up inside that transparent cap.
Exactly.
The tutorial says you apply suction until the tissue completely obliterates the camera view.
Yeah, you essentially go blind.
It's like taking a vacuum cleaner hose and aggressively shoving it against a living room curtain.
Yes.
The fabric gets sucked entirely up into the nozzle, filling the plastic tube until you can't see anything but darkness.
It's an intense visual, but it captures the exact mechanism. Only when the camera goes completely black does the doctor turn the wheel to fire the clip.
Wow.
The problem is, the suction method has a major physical limitation. It only works on soft, healthy, unscarred tissue.
Right, because if you have a chronic ulcer that's been healing and reopening for months, that tissue turns into tough, rigid scar tissue.
Exactly.
Or if you have a massive perforation, like a gaping hole, you can't build negative pressure. I mean, a vacuum cleaner doesn't work if the hose is over a hole in the wall.
Precisely. The air just escapes.
Yeah.
That is when the doctor has to pivot to the traction technique.
And this is where the procedure becomes significantly more complex.
Complex is an understatement.
I mean, if you can't suck the tissue in, you have to physically drag it in.
Right.
And to do that, they route entirely separate grasping tools down that same tiny hollow biopsy tube, right past the camera and out into the body.
Yeah.
The tutorial breaks down a few variations. You have a standard tissue grasper, which looks like tiny forceps to just grab and pull. You have a hooked tissue grasper, which utilizes tiny curved claws to grab the edges of smaller chronic defects like fistulas.
And for clarity, a fistula is simply an abnormal microscopic tunnel that is formed between two organs, or between an organ and the skin. They are notorious for being hardened and difficult to close, which is why those curved hooks are necessary to bite into the tough tissue.
Got it. But the tool that truly baffled me was the twin grasper.
Oh, yeah. The twin grasper is wild.
This is meant for large perforations. But wait, if you have a giant metal cap on the end of the scope and a camera and a thread running through it, how do you possibly fit a tool with 3 distinct moving parts down that same tiny tube?
It is an absolute marvel of miniaturization.
I mean, it must be.
The twin grasper is passed down the biopsy channel,
Okay.
completely collapsed.
Right.
Once it emerges past the cap, the doctor extends it. It has a central spine and 2 independently articulating blades, a left jaw and a right jaw.
So the doctor positions this tiny 3-pronged tool right in the middle of the hole in the patient's stomach.
Right.
They open the right jaw, grab the right edge of the hole, and clamp it shut.
Yeah.
Then they maneuver over, open the left jaw, grab the left edge of the hole, clamp that shut, and pull the 2 edges together back into the cap.
Yes. But here is the critical mechanical hurdle.
Uh-oh.
The doctor, whose hands are meticulously steering the endoscope inside the body,
Yeah.
is not the person operating the grasper jaws.
Wait, what?
The surgical assistant standing next to them is the one actually manipulating the grasper handles on the outside.
That sounds like a disaster waiting to happen.
It's definitely stressful.
You have a surgeon looking at a 2D monitor, maneuvering a camera inside a dark, slippery cavern, yelling commands to an assistant who has to operate the left and right jaws completely blind.
Yeah.
It's like a crane operator who is wearing a blindfold, relying entirely on a spotter with a walkie-talkie while trying to build a house of cards.
That's a terrifying analogy, but accurate.
If the assistant gets disoriented and clicks the wrong handle when the doctor says, open right, they could accidentally rip the stomach tear wide open.
Which is exactly why the tutorial places immense emphasis on preoperative rehearsal.
They practice beforehand.
They have to. The assistant cannot be figuring out the mechanical orientation of the tool while it is inside a bleeding patient.
No kid.
They have to mentally map the left and right blades and literally practice the tactile feedback of the handles before the scope ever enters the body.
And the high-wire act doesn't stop once the tissue is grabbed.
No, it does not.
There is a terrifying caveat to the traction method that I'm calling the golden rule.
Ah, the timeout.
Yes. Before they ever touch that hand wheel to fire the metal OTSC clip, the entire operating room has to call a formal timeout.
Right.
Everyone verbally confirms that the jaws of the grasper tool have been pulled completely inside the transparent cap.
Because if they haven't.
If even a millimeter of that metal grasping tool is protruding past the edge of the cap when they fire,
Game over.
the bear trap snaps shut on their own tool. They permanently staple a surgical instrument to the inside of the patient's stomach.
Exactly. And the nitinol alloy of the clip is designed to be permanent.
Oh, man.
It exerts immense, relentless crushing force. Trapping your own grasper essentially turns a difficult rescue operation into an absolute nightmare.
I can't even imagine the panic in that room. But even if the tools are clear, the actual human anatomy presents a massive risk.
Definitely.
This is the part that really kept me up at night.
Okay, let's hear it.
When you use that suction method we talked about earlier, right?
Yeah.
When you create that vacuum and the camera view goes completely black, how does the doctor actually know what is behind the piece of stomach wall they just sucked in?
They don't.
What?
At least not visually in that final second. The stomach and intestines are not isolated tubes floating in an empty void.
Right.
They are packed tightly against other vital organs, blood vessels, and structures.
So when you apply that intense suction, you might grab the stomach wall, but you might also inadvertently suck in a surrounding loop of the small intestine that was resting against the outside of the stomach.
Exactly.
The tutorial explicitly warns about snagging a ureter, the delicate tube carrying urine from the kidney to the bladder.
Yeah, it happens.
If you fire the clip, you've just permanently crushed the patient's ureter shut.
It is one of the gravest risks of the procedure. The tutorial also highlights the danger of operating near the pylorus.
What's that?
The pylorus is the muscular valve that connects the stomach to the small intestine. It regulates how food leaves the stomach.
Oh.
If a doctor misjudges the suction radius near that area, they can deploy the clip and accidentally staple the stomach's exit valve completely shut.
Which means food can never leave the stomach.
Exactly.
It's an anatomical catastrophe. You are literally firing blind in that final second of suction.
And this is why an endoscopist's most valuable tool isn't the clip. It's their structural knowledge.
Wow.
They cannot rely solely on the 2D camera feed. They must possess a flawless, three-dimensional mental map of the human body.
They have to see through the walls in their mind.
Before they apply negative pressure, they have to calculate. Based on exactly where I am in the stomach, what vital structure is resting 1 millimeter behind this wall?
But humans make mistakes.
They do.
And thankfully, the tutorial does outline a failsafe.
Yes, the rescue device.
Right. If a disastrous deployment occurs, say the doctor realizes they just clipped the pylorus shut, there are specialized electrosurgery devices that can break the metal clip.
Yeah.
But wait, how do you safely use electricity to shatter a metal bear trap inside a wet, highly conductive human stomach without electrocuting the patient?
It comes down to highly focused thermal physics.
Okay.
They don't just zap the clip with raw electricity. They use a specialized endoscopic probe that delivers a precise, localized, direct current.
Interesting.
The probe is touched directly to one of the thin metal struts of the clip. The electrical current rapidly superheats that specific millimeter of the nitinol alloy.
Oh, so it's not about shocking the metal, it's about localized melting.
Exactly. It raises the temperature of that specific point so drastically and so quickly that the metal loses its structural integrity.
Oh, wow.
The alloy physically degrades and snaps under its own tension, allowing the clip to fall apart and release the trapped tissue.
That's amazing.
And the current is contained entirely within the circuit of the probe and the clip, so it doesn't disperse through the conductive fluids of the stomach.
It's an incredible engineering solution to a terrifying problem.
It really is.
So bringing this all back to you, the listener, why does understanding the physics of a blunt tooth or the mental mapping of a twin grasper actually matter?
Yeah. Why should they care?
Because it peels back the curtain on the invisible high-wire act of modern medicine.
Absolutely.
The next time you or a loved one undergoes what a hospital calls a routine endoscopic repair, I hope you have a profound appreciation for what is actually happening in the dark.
It's far from routine.
It is a microscopic ballet of hand wheels, thread pulleys, localized thermal destruction, and unparalleled spatial awareness. It is human ingenuity allowing doctors to fix the unfixable from the inside out.
It truly is a testament to the convergence of mechanical engineering and human anatomical expertise.
Yeah.
But it also highlights how heavily we still rely on the fragile, brilliant mind of the operator to avoid disaster.
Which leaves me with a final thought for you to ponder.
Okay.
Throughout this entire deep dive, the recurring theme has been the blind spot.
Right.
The assistant operating the grasper blind. The doctor firing the clip when the suction turns the camera black. Relying purely on a mental map to avoid crushing a ureter.
That's a lot of faith in the human mind.
But what happens when we integrate real-time AI and 3D spatial mapping into these camera scopes?
Oh, man.
Could the endoscope of the future use sonar or advanced imaging to map the organs resting behind the stomach wall?
That would change everything.
Could the system autonomously lock the hand wheel, literally refusing to let the doctor deploy the clip because its sensors detect that the pylorus valve is caught in the crosshairs?
That is the inevitable next frontier. Removing the human blind spot entirely.
Imagine that. The ultimate marriage of diagnostic mapping and microscopic plumbing finally illuminating the murky depths of the human body.
Unbelievable.
Something to think about the next time you hear the words minimally invasive.